Meningococcal meningitis is a form of meningococcal infection that is characterized by purulent inflammation of the soft and arachnoid membranes of the brain. The disease is accompanied by a typical triad of clinical signs: headache, fever and vomiting, meningeal signs, cerebral and general toxic symptoms. Meningitis can be combined with meningococemia, complicated by infectious toxic shock, adrenal insufficiency, encephalitis. Methods of laboratory identification of the pathogen play a decisive role in the diagnosis. The basis of treatment is antibacterial and pathogenetic therapy. Overview. Meningococcal nature has 80% of primary bacterial meningitis. In the form of sporadic cases or small outbreaks, pathology is recorded everywhere. The greatest prevalence is observed in Africa and Asia, only in the meningitis belt, from Senegal to Ethiopia. About 30,000 cases are detected annually. In Western countries, residents suffer with a frequency of 0.9 to 1.5 cases per 100,000 people. World statistics indicates 0.5 million affected. The peak of the incidence usually falls on the winter-spring period. Meningitis can develop at any age, but most cases are diagnosed in children and adolescents, 80%, young people, without significant gender differences. Reasons. The etiological factor of meningococcal meningitis is Meningococcus, Neisseria meningitidis. It is a paired globular gram-negative bacterium, Diplococcus, surrounded by a capsule with cilia. The pathogen has low resistance to environmental factors, quickly dies under the influence of ultraviolet rays, high and low temperatures. Meningococci belong to aerobes, are sensitive to pH, disinfectant agents. The microbe has a complex antigenic structure. There are 13 serogroups of N. Meningitidis, differing in the composition of a specific capsule polysaccharide. The most common strains of groups A, B, C, recently record an increase in the frequency of detection of bacteria, with antigens Y and W100 and 35. The pathogen is characterized by high variability. It undergoes transformation with the loss of the capsule, shows heteromorphic growth, acquires resistance to chemotherapy drugs. The main factor in the pathogenicity of meningococcus is endotoxin, a lipooligosaccharide complex released during the destruction of a microbial cell. The pathogen is able to produce a number of other damaging substances: hemolysin, proteases, hyaluronidase, penetrate the blood-brain barrier. Fixation to the nasopharyngeal epithelium occurs due to the cilia, and the capsule protects the bacterium from the mechanisms of phagocytosis. A predisposition to the development of meningococcal meningitis is formed in conditions of a decrease in local and general resistance of the body. Risk factors are congenital complement deficiency, HIV infection, anatomical or functional aspia. The mucous membrane of the nasopharynx is damaged by smoking and RV, which increases the risk of bacterial invasion. The spread of infection contributes to the large crowding of the population. Pathogenesis. Transmission of the pathogen occurs by airborne droplets from patients with meningococcal infection or asymptomatic carriers. The entrance gate is the mucous membrane of the nasopharynx, where the primary inflammatory process develops. In 10 to 20% of cases, microbes, having overcome protective mechanisms, penetrate the bloodstream, where they multiply, initiating a short-term bacteremic phase. In the subarachnoid spaces of the brain, Neusseria are introduced by the hematogenous route, less often lymphogenously, perivascularly, and perineurally through the plate of the ethmoid bone. During the reproduction of Meningococcus, serous purulent, then purulent inflammation of the soft and arachnoid membranes develops first. Most often, the convexital surfaces and the base of the brain are affected. Sometimes the process spreads in the spinal direction. Macroscopically, the soft membrane looks swollen, hyperemic, cloudy. The surface of the brain seems to be covered with a cap of pus. The microscopic picture is represented by pronounced infiltration by polymorphonuclear mononuclear cells. The adhesion process can cause blockage of the cerebrospinal fluid outflow pathways. Classification. According to the clinical classification of meningococcal infection, meningitis refers to its generalized forms. Given the severity of the pathological process, the infection can occur in mild, moderate, severe or extremely severe forms. Meningitis caused by N. Meningitis is purulent. Clinically, it is represented by the following options. Classical. The infectious process is isolated, only the soft and arachnoid membranes of the brain are affected. Mixed. The picture of meningitis is supplemented by signs of inflammation of the medulla, meningoencephalitis, bacteremia, meningococemia. Complicated. It is accompanied by the development of local and systemic complications caused by the influence of inflammatory changes or toxins of the pathogen. By duration, the pathological process is acute, up to 3 months, protracted, up to 6 months, chronic, over 6 months. Depending on the localization of the affected cerebral structures, meningitis is divided into convexital, large hemispheres, basal, lower surface, and spinal. Additionally, limited and total forms are distinguished. Symptoms of meningococcal meningitis. The onset of the disease is usually preceded by nasopharyngitis, but symptoms can occur suddenly, against the background of complete well-being. With great constancy in the clinical picture, the so-called meningeal triad is detected: headaches, fever, vomiting. The temperature rises sharply to 40 to 42 degrees Celsius, accompanied by severe chills. Excruciating headaches are diffuse pressing, bursting, or pulsating in nature, localized mainly in the frontoparietal region, intensify at night, with a change in the position of the head. Vomiting in meningococcal meningitis occurs without previous nausea, a fountain, does not bring relief. The clinical picture is complemented by skin hyperesthesia, increased sensitivity to sound, light and pain stimuli, odors. Sometimes already in the first hours of the disease there are tonic-clonic seizures. An important place in the structure of cerebral symptoms is occupied by psychomotor agitation and increasing disorders of consciousness, from stunning to coma. Among the objective symptoms, meningeal signs come first, which appear at the very beginning of the disease and progress rapidly. The most permanent are the rigidity of the occipital muscles, the symptoms of Koenig and Brudzinski, upper, middle, lower. Children have a sign of Lesage, bulging and pulsation of the fontanelle. The patient takes a forced posture, lying on his side with his head thrown back and knees pulled to his stomach. The severity of meningeal syndrome may not correspond to the severity of the pathology. Neurological examination often reveals the asymmetry of tendon, and skin reflexes, weakening as intoxication increases, pathological foot signs. Basal meningitis is accompanied by damage to the cranial nerves, especially 3, 4, 7, 8 pairs. The presence of persistent red dermographism indicates concomitant autonomic disorders. Signs of intoxication are first tachycardia, and then relative bradycardia, hypotension, muffled heart tones. Patients have increased breathing, the tongue is covered with a dirty brown coating, dry. Complications. An extremely unfavorable option is the fulminant course of the disease with edema, swelling of the brain. The situation threatens the wedging of stem structures into the large occipital opening of the skull, which leads to a violation of vital functions. Slow resolution of purulent inflammation is dangerous by the development of hydrocephalus, cerebral hypotension. Subdural effusion may occur in young children. The result of severe or combined forms of meningococcal meningitis are infectious toxic shock, acute adrenal insufficiency. With delayed or inadequate treatment, the purulent process passes to the ependyma of the ventricles and the medulla, complicated by ventriculitis, ependymatitis, and cephalitis. In the later stages, there is a risk of deafness, epilepsy, delayed psychomotor development in children. Diagnostics. It is possible to establish the origin of meningococcal meningitis on the basis of clinical data when it is combined with bacteremia. The probable etiology of isolated forms of the disease is indirectly indicated by epidemiological and anamnestic information, the presence of nasopharyngitis, contact with the patient. Accurate verification of pathology is provided by laboratory and instrumental methods. Clinical tests. The hemogram shows pronounced leukocytosis with a shift in the formula to the left and eosinophilia, acceleration of ISR. In the cerebrospinal fluid, polymorphonuclear pleocytosis, a decrease in glucose concentration, and an increase in protein are noted. Changes in urine analysis are nonspecific, indicative of toxic phenomena. Bacterioscopy and seeding. Meningococci are detected in neutrophils by direct bacterioscopy of gram-stained smears. Seeding cerebrospinal fluid on serum agar or other nutrient media makes it possible to clarify the culture, enzyme, antigenic properties of the pathogen to determine its sensitivity to antibiotics. Serological tests. After the isolation of meningococcus, it can be identified by serogroups when setting the agglutination reaction. To detect antibodies in the blood, Ringa is used. Rapid diagnosis is carried out using ELISA, methods of counter-immunoelectrophoresis. Molecular genetic analysis. In addition to standard procedures, PCR is used to identify bacterial DNA. This is a quick and sensitive diagnostic test. It acquires special value if it is impossible to isolate the pathogen from cerebrospinal fluid or blood. Neuroimaging. Indications for cerebral tomography may be impaired consciousness, focal neurological symptoms. CT scan of the brain confirms cerebrospinal hypertension, intracerebral hemorrhages, cerebral edema. MRI with contrast is preferable, as it better visualizes the meningeal membrane, the subarachnoid space. As an additional study for seizures, EEG is prescribed to record the bioelectrical activity of the brain. Assistance in the diagnostic search is provided by an ophthalmologist, examination of the fundus and infectious disease specialist. The disease must be differentiated from meningitis of a different etiology, epidural abscess, subdural empyema. Encephalitis, acute disseminated encephalomyelitis, subarachnoid hematoma should be excluded. Treatment of meningococcal meningitis, any form of generalized infection, is associated with a high risk of death and serious complications. Therefore, meningococcal meningitis should be considered as an emergency condition requiring urgent hospitalization in a specialized hospital. Usually, patients immediately enter the intensive care unit under the round-the-clock supervision of specialists. They are shown strict bed rest. The basis of treatment is pharmacotherapy. Etiotropic. The central place is given to antibiotic therapy with penicillin preparations, benzopenicillin, ampicillin, or cephalosporin series, ceftriaxone, cefotaxime. Alternative medicines are carbapenems, chloramphenicol. First, empirical therapy is prescribed, which is then adjusted to take into account antibiotic sensitivity data. Pathogenetic. To stop cerebral edema, glucocorticoids, osmotic and loop diuretics, mannitol, furosemide, are used. Hemodynamic instability and toxicosis require infusion support, crystalloids, colloids, plasma, the introduction of vasopressors, oxygen therapy. In severe cases, extracorporeal detoxification is performed. Symptomatic. In the complex treatment of meningococcal meningitis, symptomatic drugs are used. With convulsive activity, anticonvulsants, diazepam, sodium oxybutyrate, are indicated. High fever is stopped by antipyretic drugs. Discharge from the hospital is carried out with complete clinical recovery. All patients who have undergone meningococcal meningitis should be under the dispensary supervision of a neurologist with regular examination. Consequences and residual effects are eliminated by comprehensive rehabilitation, which includes physiotherapy, therapeutic exercises, cognitive correction. Prognosis and prevention with timely specific therapy of meningococcal meningitis. The prognosis is relatively favorable. Combined and complicated forms significantly worsen the outcome. Generalized infection is always associated with the risk of life-threatening conditions. Even against the background of treatment, the mortality rate is 10 to 15%. Poor prognostic factors are focal neurological symptoms, impaired consciousness, laboratory changes, anemia, thrombocytopenia, leukopenia. Prevention implies an impact on all links of the epidemic process. With regard to the source of infection, early detection, isolation and treatment of patients, sanitation of carriers are carried out. To break the mechanisms of transmission, health sanitary and hygienic measures, disinfection in the focus. To create specific immunity in susceptible individuals, vaccination against meningococcal infection is recommended. Increased nonspecific resistance contributes to hardening, timely therapy of respiratory diseases. Thank you for watching this video. See you in the next one. Please like and subscribe and let me know which disease you wanna know next.